Can you see my slide now?
Not yet, no problem. Good morning and good evening, my friend. I am P.Y. Cho, and my colleague, Dr. Junior Tu. We both will moderator the webinar. Welcome to ICC webinar today. Professor Fayyaz is always the family member of the Chang Forum, and he is one of the most supportive colleagues to the Chang Craniofacial team in the ICC. Professor Fayyaz's team has performed more than 26,000 free cleft and palate surgery all over the world, including Rwanda, Mexico, Philippines, Morocco. And he is going to establish a new hospital at Lahore, Pakistan, where free surgery will be provided to those who in need, such as the cleft and palate, craniofacial deformities, and so on and so forth. Currently, Professor Fayyaz is the president to lead the Pakistan Association of Plastic Surgeons, and today, Professor will present the topic Pakistan Palatal Fistula Difficulty Index. The abbreviation is PPFDI, a novel assessment tool to predict the prognosis of closure of palatal fistula. By the way, he is the official ASPS International Visiting Professors. Today, we are so honored to have the two, our very important friend. The one is Rafael Dinadai from Brazil. Hello, hello, Rafael. And the second one is the Professor Sarah Yu. And Professor Sarah Yu is from Bangkok, Thailand. Hello, Sarah Yu. Thank you for
Hello, good
you
evening,
both come
everyone.
join. Thank
Yes,
you.
it's honor to me
So,
too.
and we can wait to learn from Professor Fayyaz's lecture. So, Professor, and
So,
okay, so let's go.
yeah, please go ahead.
Okay,
Next slide.
the second one.
Next slide.
Okay, please go on. The next
Next
slide.
slide.
Okay. And next slide.
So, the purpose of developing the Pakistan Palatal Difficulty Index is to have a standardized assessment. It can provide a structured way to evaluate fistula complexity rather than relying on subjective surgeon assessment. It can also help in outcome prediction. It can correlate fistula difficulty with success rates, helping set realistic patient expectation. It can also help in surgical planning, which type of flaps or free tissue transfer will be used based on the difficulty level. Next. So it can help young surgeons and trainees in understanding the complexity of cases and refining surgical decision making. It can also help in comparison of surgical outcome across different studies, centers and techniques. Next. Next. Yes. So this tool can help whether the fistula can be closed at own hospital or you need guidance and help from an experienced surgeon to close the fistula, or you have to refer the patient to a designated cleft center to avoid recurrence. Next. So we have defined 6 domain: location of the fistula, size of the fistula, shape or configuration of the fistula, single or multiple, primary or recurrent, velopharyngeal function. Next. Yes. So for the location of the fistula, we have given midline fistula as score 1, lateral for score 2, and subtotal score 3. Next. So this is the diagram where we have omitted the lateral and subtotal fistula, only you can see the midline fistula, especially the fistula over the M2 region. So our fistula in the midline will have score 1. However, if the fistula is located in the anterior half of the hard palate, the score will be counted as 3 because the anterior palatal fistula are more difficult to close. Next. For the lateral fistula, RA, LB, RB, RC, LC, the score is 2. Next. Subtotal left score is 3. Next. Subtotal right score is 3. Next. For subtotal bilateral, when both pedicles have been damaged, so the score is still 3 because most of the subtotal fistula, they fall in the high complex category. Next. So for the size, we define as less than 1 centimeter. The score would be 1. From 1 to 2 centimeter, the score would be 2. And for more than 2 centimeter, the score would be 3. Next. For the shape or configuration of the fistula, if it is longitudinal, it will be score 1. If it is transversely placed, score would be 2. If the shape is irregular, then score would be 3. Next. Yes. If the fistula is single, score would be 1. Score would be 1. There are two fistula, score would be 3. If it is more than 2, score would be 3.
I'm sorry, Professor Fayyaz. I think you have two microphones on at the same moment.
Yes.
Can you mute one of them? Because they
Yes. Next slide.
with each other. You still have both microphones open. Oh, perfect. Thank you.
Yes. So for the primary and recurrent, we say the primary fistula has primary mean which the fistula has never been operated. So it will be score 1. Operated once, score would be 2. Operated more than once, score would be 3. Next. Velopharyngeal function. When the palate length and function are adequate, the score would be 1. When the palatal length is acceptable, but function is inadequate, score would be 2. When palate length and function both are poor, score would be 3. Next. So what we did, we took 4 surgeons from 2 different hospitals. They were shown slides of palatal fistula with different types of fistula. Information about velopharyngeal status and whether unoperated or recurrent was shared with them. However, information about location, size, shape, and number of fistula was not shared. They did the evaluation by looking at the slide. The data available by 4 surgeons was gathered. Next. Next. So this is a patient with midline fistula at M4 level. M4 means at the junction of the hard and the soft palate. It has not been operated, and the velopharyngeal status is V2. So the location score is 1. Size score is 1 because it is less than 1 centimeter. Shape is longitudinal, so it is 1. 1 fistula score is 1. Never operated to close the fistula, score is 1. PPFDI is V3, so its score is 3. Total score is 8. Next. Again, the location is M4. It has not been closed previously, and the status of Ghulam is V3. So location score is 1, size score is 1, shape is 1, fistula score is 1, never operated, and the V status is B3. So it is total is 8. Next. At M5, location score is 1, size score is 2, shape longitudinal 1 fistula score is 1, never operated before 1, and the VP status is 3, so the score is 9. Next. M34, that means it involves the posterior half of the hard palate and the junction of the hard and soft palate. It has not been closed previously. The VP status is V3. That means the palate length and function are poor. So the location score is 1, size score is 2, shape score is 2 because it is more transversely placed. 1 fistula score is 1, never closed before. VP status is 3. So the total score goes to 10. Next. So the fistula is at M2, never operated before, and the VP status is V3. So because it is in the anterior half of the hard palate, so the score is 3, size score is 2, shape is 1, fistula score number 1, never operated before, score is 3, VP status is 3, total score goes to 11. Next. Again, it is M1 and M2, not operated before. Palate is normal, the function is good. So the location score is 3. Size score is 3 because it is more than 2 centimeter. Shape it is longitudinal, so 1. Only 1 fistula, score is 1. Never been closed previously. So VP status is 1. Total score goes to 10. Next. So it is multiple fistula in the midline, M3 and M5, not closed before. Palate is short and function is poor, so it is V3. So location score is 1, size is 2, score is 1, shape 1 fistula. Because there are 2 fistula, score is 2, and VP status is 3. Total score goes to 10. Next. So it is LA. LA means the fistula is in the anterior half of the hard palate on left side. Never closed before. Palate is short and function is poor. So the VP status is V3. So location score is 2. Size score is 3. Shape 1. Number of fistula 1. Not closed before. VP status is 3. Total score goes to 11. Next. Almost the same patient. Location is 2. Size is 3. VP status is 2. So total score goes to 10. Next. So this is a recurrent fistula on the left side in the posterior half of the hard palate, and the VP status is V1 because somebody has already done the pharyngeal flap. So location is 2, size score is 2, shape score is 2, recurrent score is 2, and VP status is 1. Total score goes to 10. Next. Lateral fistula RB on the right side, never closed before. Palate is short and function is poor. So VP status is V3. So location score is 2, size is 2, shape is 2, fistula 1, never closed before. VP flatus is 3. So total score goes to 11. Next. So this is RC, not RB, not closed before, and VP flatus is V3 because palate is short and palate length is poor. So location score is 2, size score is 2, shape is 1, 1 fistula, not closed before. So VP flatus is V3. Total score goes to 10. Next. Next. So this is subtotal left fistula, not operated before. The palate length is good, but function is poor. So location score is 3. All subtotal fistula will have location score of 3. Size is 3. Shape is regular. Score is 3. 1 fistula is 1. Not closed before is 1. Because palate length is poor. So score is 2. Total is 13. Next. Subtotal right, not closed before. Pharyngeal flap done already. So location score is 3. Size is 3. Shape score is 3. VP flatus is 1. Total score goes to 12. Next. Yes. Subtotal left fistula, not closed before. Palate length is poor. So location score is 3. Size score is 3. Shape is 3. VP flatus is 3. Total goes to 14. Next. Subtotal right fistula. Location score is 3. Size score is 3. Shape score is 3. VP flatus score is 3. Total goes to 14. Next. Subtotal right fistula. Very large fistula. Location score is 3. Size is 3. Shape is 3. VP flatus is 3. Total goes to 14. Next. Subtotal bilateral. Location score is 3. Size is 3. Shape is 3. VP flatus is 3. Now if you see the look at, because it is subtotal bilateral, even if we make it, even if we make it 3 plus 3, 6, so it will go to 17. But still it remains in the high complexity category. So it will be done by an experienced cleft surgeon only in a designated cleft center. So that's why we keep it 3, whether it is unilateral or bilateral. Next. So we conducted a modified Delphi survey globally with 30 experienced surgeons from Australia to Africa to Asia to Europe, North America and South America. The participants rated the relevance of each domain using a 5-point Likert scale, and the all 6 domains surpassed 70% consensus threshold. Next. Fistula location and recurrence history showed the highest agreement. 80% of the respondents, they validated the 3-tiered fistula difficulty index framework. 70% endorsed the proposed surgeon experience and institutional capacity threshold. Next. So there was good inter-rater reliability. Overall reliability was 0.87, excellent agreement. Next. So you can see for the fistula location, more than 90%, recurrence history near 90%, and then fistula shape, size, number of fistula, and venopharyngeal competence. More than 70% agreement. Next. So again, fistula size, location, configuration, number of fistula, good, good, moderately good, excellent. Total was good. Next. For the number of fistula was 0.92, fistula size of 0.85. Next. Fistula location was 0.88, configuration was 0.78. Next. So now you can again see the size, location, configuration, fistula. It was again good, good, moderately good, excellent. Overall was good. Next. So we compared the index-based high complexity with expert surgeon referral decision. Agreement rate was 91.7%. Cohen kappa was 0.81, which is again excellent agreement. Next. So it confirmed that Pakistan Palatal Fistula Difficulty Index aligns well with expert clinical judgment. It supports its use for standardized referral and triage in cleft care. Next. So you can see the low complexity, moderate complexity, and the high complexity group. If the score is 6 to 8, we will keep it in low complexity. Score is 9 to 11, we will keep it in moderate complexity. And if it is more than 11, more than 12, so it will be in the high complexity group. Our most of the subtotal patients were in high complexity group. Next. So in the low complexity group, score may be 6 to 8, and we have recommended that the surgeon has 3 to 5 years of experience repairing cleft lip and palate and palatal fistula, and he does at least 15 palates every year. But he also does 10 palatal fistula every year, and the center has low volume cleft center doing 15 palate per year, and they usually handle district or general hospital. Next. If the score is 9 to 11, it is moderate complexity group, and we recommend the surgeon has 5 to 10 years of experience doing palate repair. He handles 15 to 45 palate repairs every year, but he performs 11 to 25 fistula every year with minimum 50% of the moderate complexity group. Next. If it is 12 or more than 12, then it is in high complexity group, and the surgeon handling this group should have more than 10 years of experience repairing cleft palate and palatal fistula. He does more than 45 cleft palates every year, but he performs more than 25 fistula, mostly of the high complexity group, every year. Next. So the benefit of using a palatal fistula difficulty index is it can provide objective classification. It can reduce variability in how surgeons perceive and manage fistula. The success rate is improved by matching surgical techniques to difficulty level. Repair success can be optimized. It can help the hospital to prioritize complex cases needing advanced expertise or multidisciplinary care. Next. Patient counseling can provide a framework to explain risk, success, probability, and recovery expectation. The quality improvement, it can identify trends in post-surgical complication, leading to better preventive strategies. Next. So in conclusion, the palatal fistula difficulty index, it can enhance surgical decision making, it can improve repair outcome, and facilitates research in cleft and craniofacial care. By standardizing assessment, it bridges gaps between clinical experience and evidence-based practice. Next. So we are the 5 culprits who developed this index. Next. So this is our hospital in Lahore, where do most of the surgeries. Next. So we also train surgeons from outside Pakistan, and we can provide training from 1 month to 1 year. Next. So one of our friends from Edward, he has developed cleft WhatsApp group. We are the cleft lip, palate, complication, post-op bleeding, speech, and miscellaneous. Next. So anybody willing can WhatsApp me to join these groups. Thank you very much. And I again apologize for the problem in the presentation.
Thank you so much, Professor Fayyaz, for the great presentation. So
Yeah.
at this time, I'd like to invite our panelists for some comments. And first
Yeah.
up, I'd like to invite Professor Sarah Youth.
Hi, good evening, Professor Fayyaz, and thank you for the very informative talks. So I've seen that actually your case is quite difficult. Even me, I think sometimes I cannot figure it out how to solve the patient's problem. So this talk is quite useful. But I have some questions. That the first question is that from your score, how you determine the VP function of the patients for the last parameter, because it is just from the only physical examination, or you need further investigation, just like nasal endoscope or the nasometry. That is the first question. And another comment is that I think we need to take some time to see the validity of the score, because from your slide or from your presentation, it seems to me that even sometimes the score, in the same score, I think the difficulty is different. Or even the worst score, just like 11 or 12. Sometimes I think the approach is much easier than the less score, just like 10. So that is my comment. So we need to see or follow up a longer time. So thank you.
Thank you. Actually, basically, at our center, we have a very good follow-up of most of our patients. We have follow-up at 1 week, 3 weeks, then 3 months, then 6 months, and 1 year. However, if the patient does not come for follow-up, we call them. And sometimes I send my boy to 300 or 500 kilometers to take the pictures, because we need the follow-up picture for our record. So basically, it is the follow-up which can determine the success of the surgical techniques or not. So if we do not have the follow-up, we are never sure whatever we did it benefit the patient or not. So follow-up is very important. Moreover, if there is a difference of 1 or 2 points between 2 or 3 surgeons, it is justified. However, the difference should not be more than 2. If there is more than 2, then there is maybe problem of understanding the difficulty index in a correct way.
And what about how you determine the VP function in the last parameter?
Yes, because our speech pathologist will assess the patient and he will guide us about the VP function. So if he says that the palate length is good and the function is poor, So then we do the palate repair. But if he says the palate length is good and palate function is good, you only close the fistula, we will close only the fistula. So we always go by the advice of our speech pathologist.
So it means that it's from the physical examination from the speech pathologist only, no further investigation.
My point is that we always send the patient to our speech pathologist for evaluation of the speech. If he says that you only close the fistula, the speech would improve. So we only close the fistula. But if he says the palate length is short, palate function is also poor, so then we do the palate repair and maybe we add the pharyngeal flap in the same stage, or we add the pharyngeal flap in the next stage, or somebody can do sphinctopharyngoplasty in the next stage, like that.
Okay, thank you very much. That is my comment. Thank you.
Thank you.
Thank you, Professor Sarayus. And next, I'd like to invite Professor Rafael.
As another.
Hello, Dr. Fayyaz and all friends. I have seen many presentations from Dr. Fayyaz and also read many articles and also his book. And I can judge as my friend Sarayu, many cases are very, very challenging. And always when I see such a kind of presentation with very difficult fistula cases, I guess, how can I improve my primary cases? Because it's not easy to face such challenging cases. Looking to Dr. Fayyad's presentation, since the beginning, I start to judge myself. Can I do such surgical reconstruction? And from my point of view, number 10 was my point to try to invite Dr. Fayyad to come to Brazil to help me. Number 10. And when Dr. Fayyad showed the results of the study, it was like number 12. But with this presentation, together with another publications in the book, I guess the huge experience of Dr. Fayyad can really, really improve the cleft care around the world. From my point of view, Dr. Fayyad must receive a recognition of the cleft community. And congratulations, Dr. Fayyad, for using your experience to improve the cleft care, because the fistula reconstruction is a very, very difficult topic. Looking to the classification and this kind of grade system, how to judge experience? Because when we talk to the patients, from my point of view, if you refer to a very, very experienced surgeon who has experience, can you predict the result? Or you don't have that kind of result just now? Is that kind of opinion you must refer, but you don't have the final result at this moment?
Can you repeat the question, please? Then
Sorry?
Can you repeat the question, please?
Yeah. Looking to the your presentation, the outcome prediction sounds a very important topic to me, for example, to judge my case. I never, from my point of view, how to refer is an important topic. But is that only opinion based on like analysis of the third surgeons, or you have the outcome based on your own experience?
So basically, this difficulty index can guide the surgeon depending upon the score total score and his experience whether he should attempt this patient or not. If he has done some cases like that, and depending upon the calculation of the total score, they can decide whether he needs help from another colleague, or he or she can refer the patient to another designated cleft center where a more experienced cleft surgeon is available and they can handle it properly. So this is the main purpose of this difficulty index. So it can guide the surgeon, it can help the patient to tell them what is the prognosis of the surgical outcome, something like that.
Okay. To be honest, for many cases, even with like grading 10, I would like to invite Dr. Fayyaz to come to Brazil to help me to face the case. And but congratulations, Dr. Fayyaz. I always, when I watch your very nice reconstructions and wide fistulas, I'm always figuring how can I manage the same case. It's very hard for us as surgeons to really understand how can you fix such a wide fistulas. But again, congratulations for your hard work in cleft care, and congratulations for all contributions you have made for all of us. Thank you.
Thank you. So kind.
Okay, thank you once again, Professor Denadai, for your comments, and thank you to our panelists for your participation today. Now, our next part of our webinar is the Q&A session. So far, we have a question that is being asked by more than one participant, which is asked by Dr. Tin and Dr. Calander. So the question for them is that for this fistula score, you talk about the different types and different scores, right? Is there a treatment option or a surgical guideline that you would propose to our participants, Professor Fayyaz?
Basically, the presentation today was about the calculation of the difficulty index. We did not discuss the surgical algorithm. The algorithm we already described in our paper when we described Pakistan Comprehensive Fistula Classification. The paper was published in PRS in January 2019. But if anybody is interested, they can WhatsApp me or they can email me. I will be most happy to help. Or they can share the picture of the pre-operative fistula picture, and I can guide about the that particular patient.
Okay. Thank you, Professor Fayyaz. And I think that's the only question that we have for our Q&A session. Okay, so PY?
Yes, thank you. Thank you, Professor Fayyaz. And actually, Fayyaz already gave several his very nice palatoplasty method, and based on his tremendous, very huge data bank, because according to Professor Fayyaz, the past all the contribution, just like Professor Hafayo mentioned, in ICC, this is Professor Fayyaz the fourth time to give this such kind of the palatoplasty the topic for our audience, and every time we always can look at Professor Fayyaz really want to use a very scientific data to prove his result and to convince all our audience how much he can rate the difficulty of those the defect in the palate. And not only for the past, he tried to do a lot of surgery, not only to repair. So far, Professor want to invite more and more collaborative, like the center or any relevant the center in over the world can come join his study, and maybe can based on his rating scale, and he could pour in the result and get a very common knowledge to share for all of us. Right, Professor Fayyaz, is that your target want to show for all of us today?
Thank you very much.
Yeah, so That's a very nice presentation today. And seriously, I have to say thank you to my two important friends, Professor Sara Yu from Bangkok and Professor Rafael from Brazil. And actually, I just finished one international OMFS meeting from Singapore, and I just landed here. So you can see I look a little bit tired. So I'm so sorry. And I have this apology for today. We have some technical problem in delivering the Professor Fayyaz slides. And I will do the editing for this today's video clip, and I will share on YouTube as well. Oh, finally I can see you, Professor. Oh, you
Yeah.
show up. Oh my gosh. Oh, thank you so much. I'm waiting for you 15 minutes. Hi, can you show me your hand?
Yeah. Yeah.
Okay, thank you. So now it's a good time for group photo. Finally. Okay, thank you. And I have to invite all my friends. Yes.
Hi,
And
Jordan.
would you like to show? Hi, Jordan. Do you have any
Hi,
comment?
Dr. Honda.
Hi, thank you.
Hello, Jason. Hello, Dewey. And hello, Daphne. Kate, Professor EK. Nice to see you here. Okay, I will count to 3 and please giving you a big smile, okay? Okay, now 1, 2, 3. Thank you so much, Fukui. And thank you very much, all my friend. And looking for your come join the participation for our next meetings. Professor Fayyaz, do you any closing remark to want to say to our audience today? Yeah, because you just show your big smile to us.
I
No
would
more?
like to again apologize for the problem in the presentation today, and I will try to be careful in the next time.
No worry, no worry. Okay, and I have announced our next ICC webinar, and that is the 2 weeks later. And Professor Rami Halak from UT Southwestern will share is the artificial intelligence in the field of craniofacial surgery to us. So looking forward to his presentation in ICC. Thank you very much. Good morning and good evening. See you next time. Bye-bye. Bye-bye. Thank you,
Bye-bye.
Rafael.
Bye-bye.
Thank you,
Bye-bye.
Sarah Yu. Thank you,
Bye-bye.
Jordan, Professor Handa, EK, Fukui. Professor Fayyaz, bye-bye.
Yeah, thank you.
Have a good day. Rafael, see you in Chang'an Forum. Thank you very much.
Yeah.
Bye-bye. Okay, Junior, bye-bye.
Okay, see
Have
you
a good day.
tomorrow.